It's a pressure cooker situation for millions of women around the world. The coronavirus lockdowns have simply been brutal.
I'm announcing a COVID-19 response task force on domestic and gender-based violence.
Domestic violence is rampant in Russia, for example, where up to 40% of all violent crimes occur within families. And reports suggest that cases more than doubled last month. Pope Francis has meanwhile asked the world to pray for peace within families as the lockdowns endure. But experts say that women need direct assistance, and that includes access to modern-day contraception as unintended pregnancies rise. And in some countries, maternal deaths surge. South Africa is gradually easing its lockdown, which was widely considered one of the world's most severe. Limits on contact and outdoor exercise kept more families inside and resulted in a surge of violence at home.
Life is returning to the streets of Cape Town, but the sale of alcohol and tobacco are still banned, and tensions are rising. This is a self-help group for women who've faced violence. Under lockdown, they meet in Caroline Peters' backyard. She was the victim of a gang rape when she was young. Now she helps other women who are abused by men.
Domestic violence increased because you must remember, men are frustrated, they're locked down in the homes, they are agitated, and everyone is agitated and angry. Violent men is unable to move around, so it means that the violence has moved back into the house.
Rates of gender-based violence against women in South Africa are among the highest in the world. And it's only worsened since the start of the lockdown, according to these women. They agreed to let us film in the hope it would encourage other women to speak out. Kim's life has been marked by alcohol, drugs and physical violence. She also says it's become worse under lockdown.
Everything you said, I've been through it too. I have to tell you something important, so I want to stand up. I've made a decision, and I haven't told anyone yet. Enough is enough. I can't live like this. My boyfriend hits me in front of my son. I cannot love this man. I'm going to take my bag and leave.
Now's the time for action. Kim's already packed her bag, but they have to go and get her 6-year-old son. It's a dangerous situation. Kim's partner doesn't know what's about to happen. She stopped taking crystal meth a week ago and is leaving after 18 drug-filled years together. He's stunned, but doesn't get violent. Kim has taken an important step. She reassures her son, telling him she'll keep him safe. Where they're going, nobody is going to hit anybody. People there will be kind, and she's going to be a better mother. Kim and her son can stay at a shelter for 3 months, but their problems are still waiting for them on the outside.
And I'm joined now by Calliope Minjiru, who leads a UN effort to curb violence against women, and Elizabeth Sully. She's an expert in reproductive health at the Guttmacher Institute. Welcome to you both. Calliope, let's start with you. We just looked at South Africa, but this uptick in domestic violence is a global problem. What's driving it?
Thank you. First, to start, yes, indeed, it is a global phenomenon. We know that 1 in 3 women face globally physical or sexual violence, and in the majority, they face this violence by an intimate partner violence. But what I really want to emphasize, it's not just domestic violence. The Me Too movement and other movements, they have clearly indicated that violence against women and girls, it's a pervasive form of violation, that it happens everywhere, at home, at work, at schools, when women and girls, they are on their way to school and to work. And what drives it? It's much deeper. It doesn't have to do with some individual bad actors and bad acts. It doesn't have to do with some random acts, but it has to do with power and control and how abusers exert control over their partners and women and girls in their lives.
The challenges facing families go beyond domestic violence and into women's reproductive health. Let's look here. The Guttmacher Institute says a 10% drop in reproductive health care in low and middle-income countries due to the coronavirus would put modern contraception out of reach for a projected 50 million more women. Unintended pregnancies would shoot up, same for newborn deaths, and thousands more women would die during pregnancy. There'd also be 3 million more unsafe abortions. Elizabeth, I want to turn to you here. Those are bracing numbers. What do they look like for women and families?
You're right. They are shocking numbers, and this is just with a 10% decline. We don't know if that's what we're going to see or not. That's potentially a pretty conservative estimate of how services are going to be disrupted, because what we see are bad policies, lack of access, and redirected resources that are all going to threaten women's ability to access these services. And it's not going to play out equally in all countries and on all women. Countries that already have strained healthcare systems are going to suffer the worst consequences. And people who are marginalized and vulnerable, who already had trouble accessing these services, those barriers are going to be further exacerbated during the COVID-19 pandemic. And this is really playing out in a context where
I'm sorry, I just want to say, you mentioned redirected resources. Is that what it takes to get things back on track here? Is basically redirecting those resources back to their original purpose here, or is there something more that needs to be done at a time of these lockdowns?
There's a lot more that can be done. I think there are 5 key actions that can be taken that are not just about resources. It's about how we are using those resources. The first is we need governments to declare and make it clear that sexual and reproductive health care is an essential service. That way women can access this care during lockdowns without fear of legal consequences for traveling for care. We also need to protect and strengthen the supply chains. There's concerns about global disruptions in supply chains, and so we need to focus on how those are working at the national and the regional level to make sure that sexual and reproductive health pharmaceuticals are making it to providers and to patients. We also need to dispense our pharmaceuticals differently. So we need to allow women to access contraception without a prescription. We need to decentralize the distribution of those commodities. And we also need to consider multi-month dispenses of contraception. So we need to change how we're providing those services to begin with. We can also think about innovative models of care, that telehealth can become really important in this time as an option. So there's space to innovate and think differently about how we're providing our care. And then I think the fifth and really important point is we need to focus on the unique needs of marginalized and vulnerable populations, that we need to make sure that they are not being forgotten when we are trying to ensure that sexual and reproductive health care is being protected in this moment.
Calliope, briefly, I want to end with you. Do you get the sense that societies are taking action to do more against domestic violence at this time? Briefly, if you could.
Need to do much more, especially when we know that service providers right now, they face immense challenges. And if we consider that the basic service providers are women's organizations, that they have been struggling with financial constraints even before COVID-19, what they face right now is even for them to close down themselves. And we don't know in 1 year or in the longer term which women's organizations will be there in place to provide services for survivors. So we need to provide support to women's organizations to continue providing these services. But also what we need in the longer term is political will and increase budget allocations to programs that respond to violence against women and girls in the longer term.
All right, we're going to have to leave it there. Calliope Minjiro with the UN and Elizabeth Sully with the Guttmacher Institute. Thank you both very much. Now it's time for your questions. Let's go to our science correspondent, Derek Williams.
Why do some Middle Eastern countries have such low COVID-19 death rates while having a significantly higher recovery rate compared to the global West?
According to WHO notifications from the Middle East and North Africa, the overall average case fatality rate in those regions is currently around 2.5%. Of course, Those numbers vary widely from country to country. But many experts on medicine in the Middle East, like a couple who wrote a recent commentary in the medical journal The Lancet, also don't believe that in general that reporting is accurate, especially in countries like Yemen or Afghanistan or Syria, which remain mired in civil wars and conflicts. It's correct that a few Middle Eastern countries like Saudi Arabia and Oman have reported very low case fatality rates and high recovery rates. If you believe those reports reflect the truth, one possible hypothesis is that a low average age in the populations of those countries might be playing a role, but it's all pretty speculative.
Are rashes or hives a symptom of COVID-19?
The WHO recently included rashes and skin discoloration on the fingers and toes in its official list of less common symptoms for COVID-19. They can range from hive-like groups of red bumps to larger, flatter lesions to a condition that affects the feet that superficially resembles frostbite, what's being dubbed COVID toe. It still isn't clear whether the virus itself is causing these symptoms directly or if they can be triggered by the body's immune response. There's also still a lot of uncertainty about how common different kinds of skin reactions are in different groups of patients and also on the timing for when they show up. The studies are ongoing.
Which medical professionals are responsible for intubating a patient?
I couldn't find an unequivocal answer to this question, but I can tell you what I did learn. Intubation is one of the emergency procedures used to treat patients who are experiencing severe respiratory distress. Some emergency medical clinicians are trained to carry it out in life or death situations in the field. Because it involves placing a ventilating tube deep into your trachea, though, it's obviously much safer to perform an intubation in the hospital where patients are sedated before the tube is inserted. So I assume an anesthesiologist would generally carry out the procedure, or a properly trained critical care physician.